Good morning, everyone. My name is Anne, but most of you know me as Dizzy Anne. Thank you for joining our first webinar for 2020. This webinar is sponsored by Independent Audiologist of Australia. Their mission is to promote and support clinical practices owned by audiologists. Today we have Dr. Louise Collingridge, who has kindly offered her time to run this webinar for us today. A couple of pointers. Please note that during this presentation, you will be muted and your video will be turned off. If you have any questions, please type them in the question function you will see on your screen. After the presentation, your questions will be read out and similar questions will be grouped together. I think we'll have probably about a 10-minute question session. The presentation will be recorded should you want to watch it again. So moving on, it's an absolute pleasure to introduce you today to speaker Dr. Celene McNeill, who will be talking to us today about hearing with Meniere's. Dr. Celene McNeill is a fully qualified audiologist holding a Bachelor of Applied Sciences in Speech and Hearing, a Master of Audiology and a PhD in Meniere's disease from the Macquarie University of Australia. Celene is a specialist audiologist treating sufferers of Meniere's disease with their hearing needs and other hearing issues. She practices at Healthy Hearing and Balance Care at Bondi Junction in Sydney. Thank you, Celene.
Hello, everybody. Thank you all for joining us at this very first webinar organized by the Meniere's Disease Support Group of New South Wales or Sydney. So, I'm an audiologist, and for the past 20 years, I have been working closely with a large number of patients who live with Meniere's disease. Over this time, I have been privileged to follow the journey of many of these people from time to time, from the time of their diagnosis. I have been very inspired, I must say, by so many of them who continue to live a meaningful and happy life in spite of the unpleasant symptoms they endure from time to time because of Meniere's. What I have learned from my experience is that life does not need to come to a halt because of this diagnosis. There is definitely a light at the end of the tunnel. So for those of you who are not familiar with the condition, Meniere's disease is an ear disorder that causes a combination of 4 symptoms. Ear fullness, which is that feeling that your ear is blocked. Tinnitus, which is noise that one hears in the ear and it's not related to any external sound. Hearing loss, which fluctuates. Sometimes your hearing is good, sometimes it's terrible, sometimes it's not so bad. So the hearing does change. And the worst of the symptoms is vertigo attacks, which is that spinning sensation which sometimes come with vomiting and diarrhea, and it can last for hours. The symptoms occur in clusters, and as the disease progresses, hearing loss and tinnitus become permanent, and the overall balance becomes impaired. So I will acknowledge that vertigo is by far the most disruptive of the symptoms, and this is mostly because the sufferer loses total control of their own body during an episode. The topic of today's webinar is the hearing loss. And hearing loss is the invisible symptom. Hearing loss does not cause any body discomfort. Hearing loss does not cause any pain. Hearing loss does not keep you awake at night. But hearing loss can cause a lot of disruption in one's life. So hearing loss is the one symptom of Meniere's that can be controlled by technology. Nevertheless, it's usually the last one to be addressed. So interestingly, we conducted a survey in the last few weeks with the help of Anne Elias. And this survey, we investigated several aspects of hearing of patients with Meniere's disease. And one of the things that we looked at was how long it took for somebody to realize they have a hearing loss, how long it took from the diagnosis of Meniere's disease to the time that they acquire hearing instruments to help with their hearing. And as you can see in this graph, just explaining the graph a little bit, the vertical line here is the years that it took someone to take a hearing aid from the time of diagnosis. And the horizontal line is just the number of people who, each one of the people who answered the question. So we had 54 people responding this question, and the range varied from -5 to 44. I will explain the minors. The minors mean 3 people who had hearing aids prior to Meniere's disease. So they had a hearing loss from other causes. That's why the negative number. But from people with actual Meniere's disease, from the time of diagnosis, some had it immediate. So we had about 6 people, like here, number 1, 7, 26, 27, 40, about 6 people who acquired a hearing instrument at diagnosis, so they act upon immediately. But we had some people, or one person, who took 44 years from diagnosis to acquiring a hearing aid. So the average amongst these people was 6 years. So what this is telling us, yes, people take time to act upon hearing when they have a hearing loss. So hearing is one of the senses that connects us with our surrounding world. So hearing is very important. It's the sense that keeps us connected with people. So just a brief overview of what it's like to have normal hearing, what is required to have normal hearing. So when you have normal hearing, we have 2 ears, one on each side of the head. We have eardrum on each side. We have middle ear with tiny little ossicles on each side. We have a cochlea on each side. And then we have the auditory nerve that delivers all the information that's collected from the peripheral organ all the way to the auditory cortex. So the auditory cortex are the part of the brain. So we have one on each side. So it's the part of the brain that receives and processes hearing information. So we looked at this group of people in the survey to see what ear has been affected by Meniere's disease. So what we found was that 31% of the respondents had Meniere's disease in the right ear only, 29% on the left only, and 25% had the disease in both ears. So both of the ears have been affected by Meniere's. 10% had Meniere's in the left ear, but also a hearing loss on the right of another cause. And 5% had on the right side with a hearing loss of a different cause on the left side. So the fact that you have Meniere's disease, of course, does not preclude you from having hearing loss from other causes. Hearing loss is quite a common occurrence in the general population. It's believed that 1 in 6 Australians have some sort of hearing loss. So therefore, it's quite possible that you have hearing loss from another cause before or after you develop Meniere's disease. So the survey showed that 60% have a hearing loss in one ear only. So a hearing loss that affects only one side is also called unilateral hearing loss, or also referred to as single-sided deafness sometimes. So hearing loss in one ear only can cause a lot of difficulties. They can be quite subtle, but they can be quite disturbing and distressing at times. One of the main difficulties when you have only one hearing ear is the difficulty to tell where sounds are coming from. So when you have 2 normal ears, if you have your eyes closed and somebody calls you, you can pretty much tell where the sound is coming from. On the other hand, if you have only one hearing ear, that is not possible. You cannot tell where sounds are coming from because the brain does not have enough information to process that task. Another issue that happens when you have only one hearing ear is there's a lot of misunderstanding with conversation when it is in background noise. The brain gets very confused when there's background noise because the sound is always coming from one side and there is not enough information to be able to distinguish the background from what you want to hear. And the other side effects that are quite common is neck pain. a lot of people develop cervical spine misalignments because they are forever facing or favoring their ear, the good ear to the speaker, so they're always turning their heads to hear better, and that can develop problems with their neck. And another one that's quite common and people don't realize it's related to the hearing is that when you are in large noisy spaces such as supermarkets, shopping centers, when you have only one hearing ear and you have a little balance disorder because of Meniere's, the lack of hearing on the opposite ear can make you quite confused and it can disturb your balance further. So 40% of those surveyed have a hearing loss in both ears, and hearing loss in both ears is also referred to as bilateral hearing loss. Bi meaning two lateral sides, so you have a hearing loss in both sides. So from those 40%, 25 have the disease in both ears. 10% had in the left ear with another cause on the right, and 5% right with another cause on the left. So what does the bilateral hearing loss do? What are the consequences? So it usually causes miscommunication of various degrees, and doesn't matter how mild the hearing loss is. If you have a hearing loss in both ears, there will be some problems, some minor, but some can be quite significant, and a lot of misunderstanding and miscommunication can come out of that. So an untreated bilateral hearing loss, so if you do nothing and if you live for a long time with a hearing loss in both ears, you're going to suffer a lot of stress because you're trying to have a conversation in a group of people, you don't hear, you don't understand what people are saying. You ask people to repeat, and they will repeat once. Second time, they may speak louder to see if you understand. When people talk louder, it distorts the sound even further, so you can't understand. And that leads to a lot of stress, a lot of frustration. And eventually, people start withdrawing from social contact because it's very frustrating to try to have a conversation, so they isolate themselves. And that leads to depression and anxiety. And guess what? We know that stress is one of the main aggravators of Meniere's disease. And also we know that anxiety causes dizziness. So people who are very anxious and have a panic attack, they feel very dizzy. And the dizziness sometimes can be confused with a symptom of Meniere's disease. So when you treat the hearing loss, you can reduce a lot of these consequences. So, but why is that take a lot of time? Well, we saw that takes a lot of time for people to uptake technology for hearing. So we saw that 53% of people who were surveyed, they have a hearing loss, they have Meniere's disease, but they do not have any technology, no hearing aids, no cochlear implants, or anything to help them with their hearing. 33% wear conventional hearing aids. 11% wear a cross or a bicross hearing aid. 2% of the surveyed people have cochlear implants, and 1% have a Baha. So some people are discouraged to try hearing aids. And this is pretty much based on clinical audiology test results. There is a misconception that speech recognition in audiology tests will predict the outcomes from hearing aids. But in Meniere's disease, this is not true. So in Meniere's disease, sometimes you can have very bad results in your speech tests. And this is not because your ability to, your brain ability to perceive speech is not there, but this is because you have a long-standing sound deprivation, which means you did not use that ear that has the hearing loss for a very long time. Some people get to actually the extent of plugging the ear where the problem is, and that deprives the brain from sound stimulation coming from that side. So if you had that ear deprived for a very long time and you come to the audiology clinic to have your hearing test and to have your speech test assessed, sometimes the volume of the sound, the loudness of the sound is so disturbing because you're not used to use that ear that everything sounds distorted and you cannot repeat the words correctly. So that can happen for 3 reasons. The sound deprivation, as I just explained. It can happen because of an intolerance to sound that happens in Meniere's disease, which is called cochlear recruitment, which is a phenomenon that happens in the cochlea that makes loud sounds to be perceived as louder than they actually are. And also because of inappropriate presentation of the loudness of tests materials, and that's an audiologist problem. But what we find with Meniere's people is that if we find the right loudness, which sometimes the dynamic range is just so limited, which means the minimum sound that they can hear and the maximum that they can tolerate. So that difference is so small. But if you can't find the right balance, you find that in a great number of people, their speech recognition improves, even in the clinic, even before they start wearing any hearing aid. So research has shown that brain plasticity contributes to improvement of speech perception. So what it means is the brain adjusts to changes. So you may not have heard for a very long time. When you first put the loud sound in, everything sounds horrible and distorted. But over time, with a little bit of training, with a little bit of perseverance, things improve. So your ability to perceive speech improves with hearing stimulation. So there are different technology options available to manage a hearing in the different stages of Meniere's disease. So, but one thing that we need to always have in mind is that hearing loss in Meniere's is different. It's very different than an age-related hearing loss or a noise-induced hearing loss, which are the most common type of hearing loss that we find in our population. The hearing loss due to Meniere's disease fluctuates. And this is because the fluid that is normally in the inner ear space, which is called the endolymphatic fluid, that changes. And that unpredictable changes makes hearing change as unpredictable as the endolymphatic hydrops goes. So, and that's what causes hearing fluctuation. And hearing fluctuation is what makes hearing loss in Meniere's disease so different. So what I have here is 2 graphs. The graph on the left side of the screen is showing what happens when somebody has normal hearing. So for those of you who have had a hearing test, we put headphones on, you hear a series of beeps, and you press a button or you raise your hand every time you hear a beep. So what the audiologist is recording is the softest sound you can hear at each particular frequency, at each different pitch. So when everything is normal, you have a straight line up on the top of the graph, like here. So what we have on this larger graph in the middle of the screen is the hearing test results of one single person over time. So you can see that on the 6th of February, when they first measured, the hearing on the low frequency was down here, the black line. And then they tested again on the 27th of February, was even worse. And then on the 5th of March, went back to normal. A week or 2 later, they tested again, and the hearing is down again. And that's what happens. The hearing does fluctuate. Sometimes it goes for a period of time with no fluctuation at all. Sometimes they have those clusters of fluctuation, and it's unpredictable. So when the hearing reaches the 2nd stage, or when Meniere's reaches the 2nd stage, the hearing never goes back to normal, but the fluctuation continues, as you can see on this example here. And this was somebody who tested on the same day 3 times So the black line, the person tested their hearing at 9 o'clock. So you can see that some areas of the hearing was pretty good, close to the normal range. At 2 o'clock in the morning had gone down, 7 p.m. had gone better. So this is one person in one single day. And then Meniere has reached the third stage. The third stage is also called the burnt out stage. Is that time that everybody longs for. Everyone is waiting for the time that they reach that stage, because at that stage, the vertigo attacks don't happen, or if they still happen, they're very, very mild, not as disruptive as before. When you get to that stage, the hearing really drops. And this being, for a long time, we used to believe that the hearing did not change. But my studies with a lot of people with Meniere's disease at that stage, making different measurements over a long period of time, show that even at the third stage, the hearing is still fluctuates. Not as dramatically as on the other two stages, but the fluctuation still happens. So, before we can decide on what is the appropriate technology for each individual patient, we need a very comprehensive audiological assessment. We really need to get to know what your hearing is doing. And we do that with clinical tests. We do the hearing tests in the clinic, but we also do that at home. So we provide the patients with a phone app, and there's many of them out there at the moment, and they can do their own hearing tests at home, and that helps to monitor and to identify the fluctuation. So these self-hearing tests do not replace the clinical tests, because they don't really give you the precise level of hearing, but they are very suitable to monitor changes. So what you want to see with a self-hearing test is not the precise hearing levels that you have, but the change that will occur every time you test, if you do the test appropriately, obviously. So once we know what's happening with your hearing, we can decide which hearing aid you're going to get. And conventional hearing aids are usually the best option for patients with Meniere's disease, for the majority of patients until stage 3, or the end of stage 3. So hearing aids are digital instruments, and they are customized to equalize and amplify sounds to each individual's hearing loss. Hearing aids come in different shapes, size, and colors. So the styles available are the behind-the-ear models, and in the behind-the-ear you have those very discrete slim tubes or receiving the canal ones that have very, very small tubes and can hardly be seen when it's in the ear. And then you have the more bulky ones behind the ear with the regular tubing. So this requires a larger mold in the ear, a little bit more visible, but not too bad. And then you have the inner ear styles. In the ear styles, this is the concha hearing aid, this is the in the canal hearing aids, and then you have the CIC and the completely in the canal hearing aids, the very, very tiny ones. So to choose a hearing aid, we have to take several factors into account. First is the audiogram. So depending on the audiogram, one hearing aid might be better than the other in terms of style. But for the great majority of hearing loss these days, any style is suitable. But one thing that also we need to take into consideration is the anatomy of the ear canal. Some ear canals can be so tiny that we can really fit a hearing aid that goes inside the ear deeply. Another consideration is patient's dexterity. For some people, it's very difficult to handle those little devices, so there's no point in having something that you cannot manipulate yourself, because you are the person who will have to use that hearing aid, you are the person who have to put that hearing aid in your ear, you'll be the person who will need to replace the battery on the hearing aids. So your dexterity is also taken into account before we decide which is the best size of hearing aid for you. And there are other individual characteristics that also need to be taken into account, and your audiologist will go through all that with you before making the decision. So hearing aids also have controls, and this is important with Meniere's disease because the hearing does fluctuate. So for some people, a volume control is enough, especially those on the third stage. And volume control can be on the actual hearing aid. It can be a button on the actual hearing aid that we will adjust. Or you can have a remote control, which is another accessory that you carry in your pocket, and you press the button remotely, change the sound on the hearing aid. But these days, most hearing aids have an app that you can download on your mobile phone, and you can use your mobile phone to control the hearing aid remotely. And hearing aids these days also connect directly with your phone, so you can have phone conversation hands-free, hearing the sound straight to your hearing aids. So now we come to another type of hearing technology that I was quite surprised, pleasantly surprised to see that there's a big number of Meniere's people from this group. They are wearing the cross system. So a cross system is very helpful for neck problems. So the cross system will stop you from needing to turn your head to hear from your good ear. Because what the cross does is we have two devices, one on each side. So the device, or the hearing aid-like device that you put on your bad ear, is a transmitter. It's a microphone and a transmitter. So this device collects the sound that comes from that side and delivers to the other side and goes straight into the good ear. So these hearing aids, this system, the cross system, is indicated for people who cannot wear a hearing aid for some reason on the bad ear. This being because the hearing is so bad that the sound with a conventional hearing aid does not give enough information, or people who cannot put a hearing aid in their ear for some anatomical reason. So they are very useful to provide awareness of sounds coming from the bedside. So say if your left ear is your bad ear, you have a cross, somebody talks to you on this side, the sound is wirelessly delivered to the other side and you hear with your good ear. So it is very useful, but it does not provide binaural hearing. It's not the same as having hearing from both sides. There's also a bicross model. The bicross is for those who have one very bad ear that cannot wear a conventional hearing aid, but the other side also has some sort of hearing loss for any cause. So for those people, the system is the same as the cross, but bicross means that you have some amplification on the other side. So the sound is delivered to the bedside and wirelessly transmitted to the hearing aid on the good side, but also some amplification is delivered because that better ear has some hearing loss. So again, limitation, it does not provide binaural hearing. So what is binaural hearing? Binaural hearing is the ability to get information from both sides. So the brain, as I said initially, so we have two ears, and the brain receives most information that comes from the right ear goes to the left side of the brain, and some of the information goes to the same side and vice versa. So because of this complex network of nerve fibers, all the information collected from both sides will allow us to localize sounds and will allow us to distinguish speech from background noise. Only when you have binaural hearing, you can do these functions effectively. So another option that I am not very a big fan of for patients with Meniere's disease, but some people have it, and it's the Baha. The Baha is a bone-anchored hearing aid. You can see in the picture here, there is a little abutment, or sometimes it's a magnet. This is one of the models. There are different styles, different manufacturers, but one of them has this abutment that is surgically inserted, and then you click the actual device onto the abutment, like here. So you wear this little thing on the skull, and what this device does, it creates vibration. So when sound comes through, it vibrates the skull and sends the sound to the good ear. Exactly the same as a cross hearing aid, but the transmission is not done wirelessly from a device to another, but it's done by vibration of the skull from one side to the good ear. And by that, when people talk from your bedside, the sound is delivered to the good side. So again, does not provide binaural hearing, but provides awareness of sound coming from the bedside. The limitation is also that it does require surgery. And one of the reasons I don't particularly choose Bahas for my patients with Meniere's is because should the hearing on the good ear start to deteriorate, the Baha becomes obsolete, because the Baha is just as good as the hearing on the opposite side. So if there is a significant hearing loss on the other side, the Baha is not going to be of much use for you. So if you're going to have a Baha, I would say have a cross, have a bi-cross hearing aid. So the other option, which is the last resort, is a cochlear implant. So when hearing becomes so distorted and so impaired that a conventional hearing aid can no longer help, cochlear implant gives very, very, very good results. So cochlear implant sometimes for some patients is implanted at the same time as the patient has a labyrinthectomy. A labyrinthectomy is one of the surgical procedures used to treat vertigo. For those people who vertigo is really debilitating and they cannot really carry on life the way they've been. So they are recommended surgery, and labyrinthectomy destroys the balance organ. And at the same time, they insert a cochlear implant so that the hearing can be restored. So cochlear implant, if in both ears or if in combination with a hearing aid on the other ear, has the potential to provide binaural hearing. But that requires some intensive auditory training. And with that, people really achieve excellent results. So the management of hearing loss helps to improve hearing, also helps to mask tinnitus, and to reduce sensitivity to loud sound. So all this can be achieved by using the appropriate technology. And also helps to reduce the impact of dizziness and minimize the vertigo because the stress levels have been minimized. So I really encourage people to try to improve their hearing as soon as they realize they have a hearing loss, because long term, you just make things easier. So even say if your hearing progressed to a point that you need a cochlear implant, so if you had a hearing aid along the process, the rehabilitation with the cochlear implant is a lot faster because your brain has received constant stimulation. So I really encourage people to do something about their hearing as soon as they realize the hearing loss is there. It makes life easier. So where to go when you need help? I would say when you have Meniere's disease, you don't go buy your hearing aid at a supermarket, you don't go buy your hearing aids online, you don't go buy your hearing aids on shopping centers. I encourage you to look for an independent audiologist. So if you see this logo that I'm flashing on the screen now, it's the logo of audiologists who are independent. So this is an association. So it's a professional membership association that we It's a network, and we have clinics, not we have clinics, but independent audiologists have clinics all around Australia. So they're all independent, they're all people who own their own clinics, and they are usually more unbiased in the way they give their advice. They usually have a lot more time to spend with an individual patient. And if they cannot provide the appropriate service, they will refer you to somebody who can. So at this point, I would like to acknowledge Anne Elias for her outstanding services as the coordinator of the Meniere's Disease Support Group in Sydney, and also to thank Dr. Louise Collingridge very much for donating her time and to providing the electronic platform on behalf of IAA to enable this webinar. And I'm now open for questions.
Thank you, Celene. We have a number of questions, and I'm going to read out the question and allow you to answer. The first question relates to the stages of Meniere's. How do you know what stage of Meniere's you are in? So, for example, someone who has a low frequency hearing loss, which would be a symptom of stage 3, but only recently started having vertigo symptoms. Does that give an indication of the stage?
Okay, so one thing about Meniere's disease is that there are 4 symptoms, but the order of appearance of these symptoms, there's no pattern. So, and that's what makes the diagnosis so difficult, because some people can have tinnitus as the first sign, and that's it. And after a while, they develop some fullness in the ear, and then they notice a hearing loss, and then after a long time, they have an attack of vertigo. And that's when they take notice. The attack of vertigo is usually what brings people to medical attention. So how do you know which stage you are? The hearing loss is usually the mark, if you like. So when you're in the first stage, the hearing drops only in the low frequency. So I'll go back to my slide, so just to show you, because that's very, so now, here. So when you're in the first stage of the disease, the hearing drops only in the low frequencies. So if you look at this graph, so you have 250 hertz is a low pitched sound, 8 kilohertz is a very high pitched sound. So we measure the hearing across the frequencies. So you can see that at this end of the graph, which is the high frequencies, the hearing is absolutely normal, like somebody with normal hearing that you see on the graph on the other side. So the hearing in the first stage drops at the low frequencies only. And the characteristic of the first stage is that the hearing goes back to normal. So there's this fluctuation that from time to time it goes back to normal. So that's how we know it's first stage. On the first stage, on the other hand, the hearing never goes back to normal. So the fluctuation occurs, but never back to normal levels. On the third stage, the hearing drops to a flat line at the bottom of the graph. And as I said before, we used to believe that on the third stage, hearing did not fluctuate. And for the person, you cannot notice the fluctuation because the hearing is so bad that you can't tell if it gets better or not. So this third stage, when your hearing is so bad that you cannot notice any fluctuation. But what we see in the clinic with several audiograms is that it still fluctuates. Not a lot, but it still fluctuates. And the fluctuation is dependent on fluctuation of endolymph in the cochlea. So I hope I answered this question.
Thanks, Celene. There is another question related to the change in hearing loss, and that is, if you start with hearing loss on one side only, does this remain or can it move to both ears?
Okay, the hearing loss does not move to the other ear, because what causes the hearing loss is that something is going wrong with your cochlea in one particular side, and in that ear, that's the ear that's causing you all the symptoms. So if you have Meniere's disease, say in the right ear, you're going to have tinnitus in the right ear, you're going to have fullness in the right ear, you're going to have a hearing loss in the right ear, and the vertigo attacks that you have are coming from the right ear. It's coming from a disruption that's happening in your right ear. So the hearing loss does not move to the other side. But the fact that you have Meniere's disease in one ear does not prevent you from having a hearing loss from another source on the other side. You can have an age-related hearing loss that will affect the other side and also make the Meniere side worse. You can have a noise-induced hearing loss, or you can have, there are other things that can cause hearing loss. But also, you can, for some bad luck, develop Meniere's on the other side. And that's when the cochlea on the other side starts to misbehave and the endolymphatic hydrops starts to happen. So yes, you can have hearing loss in both ears, but it's not that it moves from one side to the other.
So just another question about symptoms, and this is around tinnitus. Now, with tinnitus, do you have, sorry, I'll just get back to the question. Do hearing aids impact or affect tinnitus? Let's start with that one.
Okay, great question. I'll just show you, I have a slide for that, okay, where is that? So hearing aids, they improve tinnitus, or let's put it another way, it's not that improve tinnitus. Hearing aids mask tinnitus. The hearing aids can cover the tinnitus. So we have two graphs here, some study that I did some years ago. So this little one on the side here is a person who has tinnitus for different causes and wear appropriate hearing aids. This is the thing. If the hearing aid is not appropriate for the hearing loss, sometimes the hearing aid can make tinnitus worse, but it's not meant to be like that. The hearing aid needs to be appropriately fitted for the hearing loss. And when they are, what you can see on this graph here is that 42% of people who have tinnitus and wear appropriate hearing aids hear their tinnitus a lot softer. 31% don't hear their tinnitus at all. And there's 27% of the hearing aid makes no difference. They hear the same with or without, but never worse. This is one thing. The hearing aids never make tinnitus worse if fitted appropriately. So the big graph here is a group of patients with Meniere's disease. And what we saw is that 55% of people with Meniere's disease wearing hearing aids hear the tinnitus much softer. 20% do not hear the tinnitus at all, and 25% will hear the tinnitus the same when they wear the hearing aid. But again, nobody hear the tinnitus worse when wearing the hearing aids, if the hearing aids are fitted appropriately. And that is this applies also for cochlear implants. So a person with tinnitus and cochlear implants will have pretty much the same result as far as the tinnitus goes.
Celene, a related question, and I'm going to shorten this question for the questioner. Is there anything that can be done about pulsatile tinnitus?
Yeah, no, pulsatile tinnitus is a bit tricky. Pulsatile tinnitus is very tricky. First thing, you need to investigate, because pulsatile tinnitus can be a sign of some other problems that need to be treated. But having said that, it's very common in Meniere's disease. Pulsatile tinnitus is very common in Meniere's disease, and it's just a benign thing. There's nothing that needs to be further investigated, as long as, well, step back. It needs to be further investigated. But if it is related to Meniere's, there's nothing nasty about it. But what can we do for pulsatile tinnitus? hearing aids is the best thing you can do, but it does not really cover completely as you would like.
So there have been a few questions about hearing aids, and particularly around the stages of Meniere's. So when you reach stage 3, is it still worth wearing a hearing aid?
Yes, I think it is very worth wearing a hearing aid, or at least trying, because I said one of the reasons is sometimes when you first put the hearing aid on, you don't get good quality, but with a little bit of auditory training, the brain starts to acclimatize to that sound, and that becomes better. And even if discrimination is not fully achieved, even if the brain cannot really discriminate all the sounds that come from that hearing aid, you get a lot of awareness of sound from that side. And that helps. The awareness of sound helps to localize sound a little bit. Not as perfect as you would if both ears are normal, but it helps. And helps to be aware of sound on the other side. And one thing that I think is very important is if you end up having a cochlear implant, the fact that you wore a hearing aid for a period of time prior to the cochlear implant will make the results a lot faster. So I think it's worth trying, and I think it's worth persevering with a hearing aid on the 3rd stage. A lot of people have very good results. Some people never achieve full speech perception, but a lot of people do with training, of course.
Can you explain the process of obtaining a hearing aid? What is the process? Does it take time to get set up for a hearing aid? And perhaps a little bit about the cost of hearing aids.
Look, yeah, it takes time. It does take time. So as I said before, it is important to have a very thorough audiological test done by a qualified audiologist. It's important to do your own hearing tests at home. And I would encourage every person with Meniere's disease to have a hearing test app and to do your own hearing tests at home. You get some guidance first, but once you understand, it's quite straightforward. And by doing that, you learn to monitor what's happening with your hearing. That helps when you're selecting a hearing aid. So, and then when we finally find the hearing aid that will be suitable for your needs, you come to the clinic and we do the fitting. The fitting can take time as well because we are dealing in some case or in many cases with a very reduced dynamic range. So we need to really find that balance with the amplification. But once that's done, once that's done, there's still a chance, of course, there's a great chance that the hearing will fluctuate. So you have to have the appropriate instruments to deal with this fluctuation. Sometimes people need to be able to program their own hearing aids at home, and I do provide them with the instrumentation for that if it's really required. Many people can do all the adjustments to cater for their fluctuation just by using a volume control or a phone app, because the phone apps these days with the modern hearing aids, with the latest hearing aids, they're very sophisticated. You're able to adjust bass and trebles on your hearing aid just by the app, and that can be quite useful for patients with Meniere's. But this is something that needs guidance. It's not something that you can just do randomly. You need to know what you're doing. And that's what the role of the audiologist is, to empower you, to teach you how to use these instruments to the best of your ability. And to, in terms of cost, it varies. Hearing aids, the price of hearing aids vary. But I think, yeah, what happens, at least in my clinic, and I know that a lot of independent audiologists do that, and I think that's quite good, especially for patients with Meniere's disease. We tend to unbundle the price, so we separate what the hearing aid costs to the services that we provide. So the hearing aid itself doesn't cost as much when you buy from an independent clinic than you would from a place that bundles the cost. So because the place that bundles the cost, they charge a lot of money for the hearing aids, but then they say they provide everything else free. In an independent clinic like mine, for example, I charge less for the hearing aid, but I charge for my time as I go. So if you need to see me, you will pay for my time and my services, but the hearing aid price is separate from that. And that allows me to have a lower price for the hearing aid. But as I said, it varies, especially at this time. We are going through a major change in the hearing aid industry with all the online sales. So there's a lot of offer out there of old model hearing aids that have been sold for bargain price. And I must say, there's nothing wrong to buy a hearing aid online. If you already are an experienced hearing aid wearer, if you have been wearing hearing aids for a long time, you will know more about a hearing aid than a young audiologist that is trying to sell your hearing aids in a clinic, you know. So for a very experienced person, there's nothing wrong to buy the hearing aids online. But if you're doing that for the first time, I would say you're wasting your time and your money, because you eventually will have to go and see somebody to help you to adjust that hearing aid appropriately. Did I answer the question?
Thanks, Celene. There are a few more questions coming up about apps and where to get them, the apps that you can use for hearing testing at home.
Okay, so you just go to your app store if you have an iPhone. If you have an Android phone, I don't know where you go because I don't have one, but I know that you can easily find wherever you find your apps. So if you just search for hearing tests, and there's a number of them, and you just play with them and see which one you find easier. But what you want from a hearing app is an audiogram, because some of these apps just test, they say they're doing a hearing test, but they're testing your ability to hear speech in noise, and that's not what you want. You want a hearing test where you hear the beeps and you measure how soft you can hear each beep. But there's several of them up there.
We've had a few other questions about some more specific symptoms and the experience of living with Meniere's. One is related to hyperacusis, and what is the best approach already using a Bifrost system? Would you like to make a comment?
Okay, let's talk about hyperacusis. Hyperacusis in Meniere's disease is not really hyperacusis. Hyperacusis, let's say, is hypersensitivity to sound. So patients with Meniere's disease have sensitivity to sound because they have a damage to the cochlea, and the damage to the cochlea causes a phenomenon called recruitment, and recruitment makes you perceive loud sounds louder than they really are. So some people get a bit confused. They think that is hyperacusis. So, but that can be addressed with hearing aids, because hearing aids do have, we can play with the dynamic range of the hearing aid to make loud sounds comfortable. And another thing that happens over time, you desensitize like anything else. So sound that sounded pretty loud to start with over time becomes normalized. So another point to be very careful with patients with Meniere's disease, and I have seen that so many times, people tend to overprotect the affected side. So you say have Meniere's in one side and you feel that sensitivity to sound, people start to be overprotective of that ear. So they start wearing earplugs, they start covering the ear in situations when it's not appropriate. Of course, you need to wear earplugs. Earplugs are important if you're going to a loud concert. Earplugs are important if you're using a power tool. That applies to anybody with normal hearing or hearing loss. But when you have Meniere's disease, you do not wear earplugs just because you want to protect that side. You don't sleep with earplugs. That is the worst thing you can do, because the more you protect your ear, the more sensitive your brain becomes to sound. It's a little bit like wearing sunglasses indoors. If you do that, or if you live in a dark room, when you go out in bright sunlight, you can't tolerate the light. But the brain is clever at adjusting. So if you think you have hyperacusis, the best thing to do is to start exposing your ear gradually to sound. But if you have Meniere's disease, I can bet my bottom dollar that you do not have hyperacusis. Hyperacusis really is a central phenomenon. That's the brain problem. It's not an ear problem. And Meniere's do not have a brain problem. Meniere's is an ear problem.
Thank you, Celene. We have had a few other questions that are very specific symptoms, but I think that what we might do is allow those questions to go to email because I am aware that we've held everyone's attention for a long time, and we are going to hand over now to Anne to close things off. So thank you to everyone for their questions.
Thank you, everyone, for coming to this first webinar, and particularly thank you, Celene, for volunteering your time today. Your presentation was truly informative, and I know we will all leave with knowledge up our sleeves. You know, if you ever want to do this again, we'd be more than happy to invite you. Thank you, Dr. Louise Collingridge, independent audiologist, who has kindly sponsored her time coordinating this seminar. And finally, please feel free to contact me if you have any questions or contact Celene with questions, and enjoy the rest of your weekend. Stay well. Thank you.
Thank you.